people really are looking and hunger for a natural, authentic outcome and to age well, but not helplessly. In reality, if you use your muscles appropriately, you'll actually age better. First thing when we came in, I was like, I didn't do my hair.
Neither did I.
Exactly.
You're fine.
I will never have a facelift.
How come?
Because
Dr. Doris Day is a board-certified dermatologist. She has a popular aesthetic dermatology practice here in New York City, and she makes frequent media appearances. She has a master's degree in medical writing and has written many books on beauty. Today's podcast is sponsored by Feel Confident. For high-quality skincare and hair care at affordable prices, make sure to check out feelconfident.com. So I wanted to start with a quote because I was listening to one of your podcasts from a few years back, and you had this great line. So I'll read this to you and then get some more thoughts. So you said, "Beauty is in all of us. If I can help somebody see their beauty before I even touch them, then any treatment I do to help enhance and celebrate their beauty will work better, will last longer, and will have the impact that I intend, which is for them to have a better life." That was really gripping, as beautifully said. And for me, I've always been interested in like the interplay between beauty and like confidence, self-confidence, just feeling confident and how they can affect each other. So I wanted to just get your thoughts on that.
Yeah, it's absolutely true. I think when I see somebody, I always thought about how when you look at somebody and you don't really know them, you could think, wow, they're so beautiful. They look amazing. And then you get to know them and they maybe aren't quite as beautiful. And someone who you look at and you think, they're okay. I mean, they're average. And then you get to know them and you just see their beauty because their confidence, their personality, their essence comes through. So I think everybody has beauty. It's a matter of us learning to see it. And as physicians, our job is to help patients see their beauty, because I hate the idea of going from more flawed to less flawed, right? Somebody comes in, you give them a mirror and they go, ugh, and then they point at like lines and folds and wrinkles and they say, I don't like these things. And they go, okay, I could do this and this and this to fix that. But instead of saying, well, what do you love about how you look? You have beautiful eyes, beautiful bone structure, the way your hair frames your face, something that's special about them. Even a little bit of an asymmetry can be especially beautiful. Marilyn Monroe was not perfectly symmetric. And if you made her two rights or two lefts, she wouldn't be pretty.
None of us are.
Exactly. And we actually prize symmetry because it's so rare. But so much of what makes someone beautiful are those idiosyncrasies, those expressions that they have and things that kind of come out as you get to know somebody. So one of the things I think is most important in being an aesthetic physician is that I always think we don't just want our patients to look better, we want them to be better. Because what is the value of appearance? It's not just for the sake of a look, right? There's an idea that you want something because of that. You want people to think you're more youthful, maybe fertile, relevant, important, all those things. You're conveying something about yourself. And that's what I try to focus on. What is it you're trying to convey? And how can I help you get there? Or how can we redirect so that you realize, even if you're not that, even if you're in your 60s and no one's ever going to think you're 20, but you can have a beauty that surpasses the instinctual look of youth that we think of as beautiful to something that has a higher quality beauty where you go, this person has lived a life. They've accomplished, they've had ups and downs, and maybe they're grandparents or they've lost loved ones or something, but yet they're still here. They've survived all that, and it's so beautiful.
Yeah. Yeah, our faces, our bodies, they tell a story. And so trying to turn back the clock too far, I think can erase some of that for sure. And I like working with just like happy people or like optimistic or positive or confident people to begin with, because then I'm like, can I make this person happier? I'm always trying to like process that during consultations and, when I see patients. And when they start off really, really miserable, I feel like I can't, no matter what I do, no matter, like it could be a home run surgical result, but they're still kind of miserable. And so it's like, maybe the result of the procedure, whether it's surgical or non-surgical, will be great and make them look prettier or whatever. But if they just don't feel right inside, it's just like, it's not going to be a great net positive.
No, if they can't start out by seeing what they like about themselves, all they're going to do once you make that better is find the next thing they don't like about themselves. And that's a no-win situation for anyone. If somebody comes in and they point out lines and wrinkles, and I tell them, well, okay, so you have some movement that makes you authentic and beautiful, but that is coming because of this. So if I can treat the source, I can redirect that. And I don't think that lines make people look old. I think what makes somebody look old is skin quality, it's expression, it's something you emote, it's posture, facial posture, body posture. And people develop really bad facial posture because I look at women as they age and they start to furrow and pucker their lips and hunch, and almost like they're saying, I'm invisible to the world, and they're allowing that to happen. So it is a battle to fight against that. But the patient that worries me is the person who wants to fight every single wrinkle as if solving that will change something else in their life. And one is it's not possible. And two is skin quality, all those things are really not about lines and wrinkles.
Yeah, for a lot of it, just form and structure. And yeah, people, I think, over-fixate on specific things that are like not that big of a deal. Also, though, I like to always get the information from a patient of like what bothers them. It's interesting when it comes to hair. I might look at someone and think like they clearly want like their hairline, better defined or whatever. And they'll tell me like, no, it's just this spot on the top of my head that no one can really see. And yet it bothers them so much. So like, I don't jump to conclusions. I just ask them like, and then sometimes I'm really surprised by the response. But I prefer to just treat more like to what is really problematic for them, and as long as I can see it, and relate to it, versus just I don't love the question of like, well, yeah, what would you change? Because I'm like, well, like we don't need to change anything if you're content with how things look, and if you hate it all, then I still can't change everything. So anyway,
I had a patient who came in and she was probably in her early 70s. And I followed what you said. I did the same thing. I asked her why she was there. I was sure she was going to say that one cheek was so much different than the other because her asymmetry was so profound. And she pointed instead at her marionette lines, the lines from the corner of the mouth to the chin. And I was so surprised. And I couldn't help myself. I said, well, I could also balance the cheeks to make them a little bit more symmetric. And she said, well, that's how I identify. They've always been that way. And that's just me. And I was like, oh, okay. So I did what she asked. She was happy. It was fine. She came back 2 months later. And in the meantime, I went on my radio show. I talked to other patients. I lectured to the residents. And I said, I learned this great lesson. This woman was so happy with her asymmetry. And always we have to respect the boundaries of like what they want. And we may see it, but it doesn't mean we have to correct it. And then she comes in and she says, yeah, I want you to fill my cheek. And I was like, but wait, I just learned so much from you. This was like a profound thing for me. It really affirmed the idea that patients know what they want and they don't have to be symmetric. They can be happy. And she said, no, you were right, though. She said, I looked at pictures. I didn't realize how much it had changed. So I want my asymmetry, but not quite this strong of a difference. And then she was really super happy. And the thing about that is I agree with you about going and taking care of what they want. But I think a lot of patients are emotionally attached to what they see. They see an older relative. I mean, when you think about it, when you're little, everybody's old. And so you see things in someone, whether they're your aunt or uncle or parents, and as you grow and you start to get those, that becomes the idea of old. And old means death and loss and mortality. And nobody wants to be faced with that. So there's an emotional attachment, not so much of a dysmorphia, but an emotional attachment to that particular thing that they focus on. And then the second problem is that they just don't know that if you balance out their face in other ways, that they couldn't know whether it's the temples or the lateral cheek or the jawline or the neck, or whether it's devices or surgery or injectables, that you can make that area look better by indirectly affecting it, either by distracting from it or by balancing away from it. So some of it is not just saying, well, what bothers you, let me just do this, but educating them as to what could be driving that, and then walking that line of not overwhelming them and saying, I'm going to throw 10 things at you. And it's a difficult conversation sometimes because it's a lot of information, but I think it's important to understand where they're coming from about why that bothers them, and then address what we can do to make the face as a single aesthetic unit better.
You're right. Education is a huge part of this. And I think we need to sometimes just tell them that, hey, you're looking at this, but you're maybe missing, the forest from the trees. So I
Yeah.
think that's a big part of it too. So it's that interplay of like hearing them out, because you know how some people practice is just like cookie cutter. Everyone gets the same nose, everyone gets the same whatever types of injections. So, but it is that interplay between like hearing them and what really bugs them, but also having them trust you as the provider, as the expert professional to guide them along as well.
I think social media helps with that, because with social media, I've been doing a little bit more in the posting where I'll sort of talk about my idea of what I think is important, whether it's about new procedures or treatments, and I'll show some before and after sometimes, not that often, but sometimes. And it sort of helps people get to know you. Same thing with doing the podcast or the radio show, is that people hear you talk for hours at a time, and that sort of will attract the person who wants what you do. There are people who do want a lot. They want to be filled, and they will find that person to do it for them, but they won't come to me because I'll say no. And it's okay. I'm not the right doctor for every patient, and patients have to find their way. But social media sort of helps you sift through to see who matches what your expectations and your desires are. And I'm really so impressed with how much people really are looking and hunger for a natural, authentic outcome, and to age well, but not helplessly. So it's not an all or nothing approach. It's not that I'm not going to do anything because I want to age gracefully. Well, I mean, you've had too much sun, you've had stress, you've gained and lost weight, you've had all these things happen in your life. That's aging you beyond your years. So we have these treatments to adjust for that. And that's what I think is aging gracefully, not just saying, I'm just going to accept those things and, allow all the damage to go through. So that's another conversation, is that aging gracefully doesn't mean not doing treatments. It means doing treatments that are leaving you looking like the best version of yourself in a very authentic way, and not trying to get rid of every line or wrinkle.
I had one thing to talk about with social media. I didn't have too much, actually. Sometimes these conversations go all about into social media, but anyway, I wanted to ask you about like these filters on social media and how they're changing our skin or the appearance of the skin, and like what that's doing to, people's perceptions and maybe buying habits, and because a lot of people are putting those filters on because they want the skin to be super smooth, but then in reality they look different.
Yeah, there's two different types of filters. I think there's one filter, like we have lighting to try to help get rid of shadows. So there are some filters that can help you kind of get rid of the distractions that are taking away from your features. And then there's filters that actually change how you look. And I don't mind the filters that will just smooth things out a little bit, because that is still projecting who you are, and adjusting for lighting angles and other things, shadows that form. So it kind of helps you show yourself in your best light. But when people start thinking that that filter is the real world, and that you can or should get rid of every pore, or have, I don't know, eyes that look a certain way or cheeks a certain way, then it becomes unrealistic. It's like me going in and saying, I'd like blonde curly hair. Like, I'm just not going to have blonde curly hair. I mean, I could dye my hair blonde and curl it, but it's not going to stay that way. And it's not going to necessarily suit me. So the idea of what these filters do on a long-term basis, if you don't have the bone structure for it or the support behind it, then you're not ever going to be that filter. And the reality is that with age, the reason why you can't look 20 at 60 is because your architecture has changed. The bones have shrunk, the soft tissues have expanded, the ligaments, the muscles, the fat, the layers of the skin all age at different rates. And then there's facial expression on top of it and overall health. All of those affect how you look. You have control over a lot of it, especially in your younger years. As you get older, it's more genetics, but when you're young, it's mostly lifestyle choices. And I always tell people nothing looks more beautiful in your 50s than sun protection in your 20s. Yeah. So people want to do all these crazy things, but really what they need is sunscreen.
Yeah, prevention. I had a whole chat with a buddy of mine, Dr. Adam Nabatian, and he's a dermatologist and a Mohs specialist. And the views on that video so far have not been great because it's not necessarily like plastic surgery, but people don't realize like that is like the core of it, trying to prevent these problems, and it's just so critical. So we spent a lot of time talking about it, and so far not many people want to view it, but I think over time it'll do fine as a video, but it's just like a critical message that isn't always getting across.
Well, I think people who've had a skin cancer will want to hear that or see it because there's so much information in that. To be able to sit for an hour and listen to someone who does it, talk about what people go through, how to prevent it, what the process is like, is such an important educational tool. So that's really great that you did it.
Yeah, thank you. So since the start of your private practice, like what changes have you observed in the aesthetic industry in general? Like some of like maybe some great accomplishments in the industry versus like some missteps. Like what are some of the highlights?
Well, I'm lucky in that when I started in 1998, Botox wasn't even FDA approved yet. We didn't have any hyaluronic acid fillers. We had Zyderm and Zyplast, and then eventually Cosmoderm and Cosmoplast. And we were using all these products. We were using Botox off-label, but the approval didn't come till later. And I was lucky too because there wasn't anybody in this space. So when it was time to do the FDA trials, I was there. So I got to be one of the sites for the FDA trials for Restylane. So I've been using it since before it was approved, which is kind of fun. The other thing that's really cool is that as new products came along, because in the US, going through the FDA process really slows that pipeline. In Europe, there's over 100 hyaluronic acid fillers. Here we have close to maybe 20 now. That's about it. But they would kind of trickle through every few years. We had Restylane, then we had Perlane, which is now Restylane. Restylane Lift is now, Perlane became Restylane Lift. We have, then we had the Juvederm line, then we had Voluma, then we had a few other ones that have come along. And Sculptra, which is amazing. It's a biostimulator. I think most of the HA fillers are also biostimulatory. And so the learning for me has been, one, that these products last a lot longer than the FDA trials and what's written on the box. So if you do an FDA study and you go 6 months, you can only make a claim of 6 months. But if you look at the data at 6 months, the product is still at its peak. It's not gone. And the product can be there depending on the plane of the skin, the metabolism of the person, the area of the face injected. It could be there. Yeah. Under the eyes, it could be there 15, 20 years indefinitely, really. The difference between that and a permanent filler is that it's dissolvable, theoretically at least, right, with an enzyme, if it's hyaluronic acid. Sculptra will fade out, and the Radiesse will fade out. But the hyaluronic acid fillers we're seeing more and more can last a lot longer than we think, and they behave differently as they break down. My learnings have been, one, that when we get new products, we get really excited. So when Botox, the first neuromodulator that came on the market, came out, we froze everybody because we could. It was like, oh my God, we can make people not move. This is so exciting. And then as it got more areas, we just froze faces. Then the learning was, wait, we can, but we don't need to, and we shouldn't. So we can redirect movement. One of my biggest learnings about neuromodulators, and I'll use Botox as a generic, but we have 5 available now. We have Botox, Dysport, Xeomin, Jeuveau, and Daxxify is the newest one, which lasts a little bit longer and does have different skin properties. But what I've learned is, and I've learned to articulate, is that you have 2 different basic movements in the face. You have expression and you have function. So one of the areas where I really dislike neuromodulators for a full freezing effect is the forehead. And I see so many people who come in and they cannot move their forehead at all. They can't lift their brows. And there's 0 chance that you can do that without dropping the brows. I mean, pure biology says that if you eliminate a muscle that's lifting,
the only muscle
that's lifting, you're not going to be able to lift. You're going to atrophy or thin out that muscle, and you're going to drop the brows. You're going to age faster. But if you only partially do it, and that person relies on that muscle to hold the brows up, you actually make lines worse. Even if you fully eliminate it and fully freeze it or paralyze it, you are going to make the lines worse. Why? Because it's a function. As we age, as young as in our 20s, the brows start to drop. When the brows drop, your inclination to look awake is to use your forehead muscle, the frontalis, to lift the brows, to open the eyes so that you can seem present and relieve the pressure of the heaviness. And it's insidious. It happens really young, like I said, as young as in your 20s, and then more over the years. So if you eliminate that movement young, you're not teaching someone not to do that, but the brain is still trying to do it. So as soon as it wears off, you're going to do it harder. And eventually you make the lines worse, or you have to freeze it more, and you're going to keep on aging. So I always talk about the ear lift. So I can lift my ears. I've taught myself to lift the ears instead of the brows. So instead of lifting from my forehead, I try to lift from my ears, and I've managed to do it. So I can fully move my forehead, but I don't. I lift my ears instead. And it took me a year to learn how to do it. Not everyone can do it, but the majority of people, if you try hard enough, like I see people saying, I can't do it, then they smile big and their ears lift. I'm like, you just did it.
Okay.
So you just have to learn to identify those muscles. But understanding your own facial expression and how you can learn to control that has an effect. So women, as they age, they often frown. And that's a change in architecture that drives that. So you have to work hard to actually look in the mirror, find a neutral expression, which if you didn't look in the mirror and see that it looks neutral, would feel like a silly smile because it's using muscles to lift. But if you practice holding that expression, you will fight that pull down and you will not have the extra jowls and the frown look at rest. But we have to focus on our expression. Instead, people just want someone to inject or do a lift or do something.
Quick fix.
A quick fix. But in reality, if you use your muscles appropriately, you'll actually age better. And you'll still do some of those treatments because we want to improve skin quality and we still need some volume help. But you'll need less product and you'll look authentically much better and you'll still be able to move.
Yeah, interesting. I have a few questions about all of that. One is, so if, like, say a young woman comes in to your office, late 20s, early 30s, with some forehead wrinkles and wants you to inject some neurotoxin, do you just say, like, no, let's just talk about exercises? Okay.
I try to say, well, let's understand why that's happening. We look at the movement and an asymmetry. Oftentimes in the 20s, what we start to see is the asymmetry comes through. Most people are stronger on one side than the other. So what I do is I point that out, and then I'll do a little bit on the stronger side to weaken the stronger side, which will allow the weaker side to move better. So I will balance it out, but then we'll talk about how to get rid of the lines, whether it's using a device. I have Photona, which does a really nice lift. It's a laser. I have SoftWave, I have Thermage, I have Alt-Therapy. I have all these devices that can lift the brows. So we can actually work on lifting the brows. And when you do it young, you do it once a year or so, and they can still make collagen. So you're going to really do the most impact then. Talk about preventive. That's a great preventive. As opposed to a Botox for prevention when you have no lines and you're barely moving, you're not preventing anything, you're throwing away money. So if they are moving pathologically and frowning all the time, or they're raising their brows all the time as an expression and a bad habit, I'll adjust. If it's an asymmetry and one side is feeling weaker and I can see that they're starting to pull on the other, I'll balance it out and I'll go between the eyes and the glabella to lift so that they feel that opening of the eyes, and then teach them not to make the expression. But I think awareness is key. Balance is very important. And then showing them a different path. So instead of saying, no, I don't want to do this, I'd say, I understand what's bothering you. This is the way that I think would be more fruitful and longer lasting to affect it and fix it.
So yeah, so early on, it seems like you were using like higher doses of the neurotoxins and people were freezing faces. And then now it's like this very nuanced approach of like, do we use it at all? Do we use some other treatment? Do we use small doses only on one side that's stronger? So I guess that's been some of the
combination. It's always saying there's not one thing that's going to fix everything.
Yeah.
So it's understanding that we have so many tools. This is one tool, and used well, you can affect how people age. And where I saw this really works is through COVID, because we had people who came in regularly and then couldn't come in for at least 3 months, sometimes 6 months or longer, depending on how affected they were by COVID emotionally in many cases. But they still aged better because they were expressing differently. They weren't losing all their expression and then getting all their expression back. What we did was we helped to redirect gently and point. And it's different every single time. When I inject somebody, left and right side of the face is different, and every treatment is different based on where they're at the moment. So it's not like, oh, I figured out exactly what you need, that's what we do every time, because what I did is going to change how they move gently, and then next time I'll keep adjusting for that. So but they aged much better even through COVID when they couldn't get the treatments as often.
Yeah, sometimes it takes like stepping away and not doing something to then figure out what to do next. I mean, I think I see some of these TikToks where people get their like lip filler dissolved and they look so much better and they look so normal.
I had
And
that
it's like,
today.
what? Like, and then they were living this other way for sometimes many, many years or decades plus. And then it's like, well, all they have to do is actually just reverse it. And yeah, maybe it doesn't go back to like their original state, but it still just looks more normal.
I think that's so wonderful when they feel that way. I see sometimes that around the eyes, especially when they get the filler dissolved, they've had so much filler there that was puffing out, and now it looks bluish, which happens over time as the filler breaks down, it pulls in more water. But then you dissolve it and they feel deflated. So it's kind of scary sometimes when you lose filler and you realize where you would have been without it. And even though that would look good, it's the contrast is so much. But dissolving lip filler is a big deal, and it's fortunately happening more and more. And my hope is that we'll do it less because people will get less, and they'll do it more carefully. I've learned about the lips that there's not a lot of room in the lips. So putting a whole syringe into a lip doesn't necessarily make sense. And even if you're going to do that, it's probably most cases better off being done over a few visits where you allow it to settle and assimilate, and then you can just touch it up as you need. But the idea of just shoving product in, the product has nowhere to go. It's going to migrate around the lip because there's just not space there.
Yeah, people, I think they pay for a syringe and they want to get what they paid for. And I try to, at least when I was injecting myself, it's been like 2 years since I've done that, but I used to remind them that, hey, like you're paying for like an aesthetic outcome. You're not really paying for the syringe. And I think some people got that and some didn't. But yeah, I think less is more in general with filler.
Yeah, so I don't charge by a syringe.
Mhm.
I'll just do an area, and if I use a little bit, I use a little bit. If I use a lot, I use a lot. But fortunately, again, it's what comes to you, and I don't advertise or anything. So my hope is that somebody will go out and be super happy, and then that's the word of mouth that gets it there. But I agree with you. Somebody who feels like you have to use the whole syringe, or honestly, the problem too is the way people are trained. I mean, I remember when I would go to some of these sessions, and I continued to train. Like I as much as I lecture, I listen to other people too, because you're always getting tips and tricks and learning from everybody. We all learn from each other. And the best part of medicine is lifelong learning. But in the beginning, when the companies would have their, usually nurses, sometimes doctors, explain and train the doctors, they would say, well, you can there's always some place you could put a syringe. Like the idea is to do more, and there's always some place you could put it. Well, no, there isn't. And sometimes you just not do it and not put in more and have the person come back later or think about it. But people really do appreciate when you guide them and say, you don't need anything today. You look beautiful. Or let's talk about basic skincare. Let's talk about devices. Let's talk about different ways we can get you to your goal. That doesn't just mean only more filler or more neuromodulator.
Yeah, I mean, I talk people out of surgery, at least surgery now, very often, and like especially for hair. Number one thing that I look for is like stability of one's hair before offering them surgery, even if the surgery is in a few months. But if the last 6 months, a year plus, like it hasn't been stable, they continue to lose. I'm like, we have to focus on medical therapy, stabilize you. And some people don't want to hear it, or they say like, I'll do that, but like, let's like move towards surgery. And I always say, now's not the right time. Let's do this other stuff. Let's revisit in 3 months, 6 months. This is elective stuff. So you don't have to jump into this and do this now. And sometimes they get really frustrated, but I'm like, if those people want to leave and go somewhere else, I'm fine with that.
Yeah, somebody will do it. Actually, I just had somebody today with this exact question about hair. And what I told them, we were talking about finasteride. I sometimes use dutasteride, topical minoxidil. And they were like, well, I was going to do a hair transplant. I said, that's great, but you don't want those transplanted hairs to be sitting there by themselves, right? So you have to stabilize, and otherwise they're going to plan for complete baldness. And that's a whole different transplant than planning for somebody who's stable. So you need to be, I say, I'm so happy I say the same thing. And I don't do hair transplants. I refer out to you, but transplants are a very specific approach where I feel like if you don't focus on it, you're not doing your patients a service. So I was trained in transplant, but I would never do it because I'm not going to spend all day doing it or spend enough time doing it to feel that I could do it better than someone who does it all the time.
I recently put out a video literally like a few weeks ago on YouTube about advanced hair loss. And the title of the video is something very flowery and like how to regrow your hair. But we try to attract a wider audience whenever we can. But in essence, it's like a very technical video about advanced hair loss. So like Norwood 6, 7, mostly for guys. And it's going into actual numbers. I don't usually like talk about like numbers, like how many hairs do we have on our heads, and like 25% usually is like in the donor area. So if you're Norwood 6, 7, you're trying to use that 25% to replace 75%. The numbers don't work out, and I give examples of like my patients who were in that position. And I just recently posted on my Instagram one of my patients who sent me a text message, and I posted his picture like with him in the sun, and there's sun glaring down. You can see that there's still see-throughness, but the guy's got hair in areas. And then the next picture is like his big bald head from pre-op, and he's 2 surgeries in with me, over 5,000 grafts. And I'm like, this guy's happy, but he was realistic, so
right.
You're not going to get that really thick density. And so
you want to frame the face.
Yeah, exactly. But like I always tell people, like you have to build on a solid foundation, and that comes down to medical therapy. So anyway.
I have issues. I wonder what you think about oral minoxidil. So it's not my favorite thing. I try not to prescribe it because I do worry about the side effects of it. But God, it's taken off. I feel like it'll go away again, but it's really taken off. Do you think it's here to stay? Do you think it's good? Do you prescribe it?
I like it. Yeah.
You like it? Oh.
I just filmed a video literally today why I hate topical minoxidil.
Oh, good. Well, this is good.
But I do like oral minoxidil.
So why do you hate topical minoxidil, and why do you think oral minoxidil is so much better?
There's like 4 main reasons. Well, first of all, it's toxic to our pets, the topical stuff. It's toxic to pets,
you have to be careful
cats, dogs. Yeah, you gotta be really careful. So oral, you're less likely to have them like swallow your pills. Then like you put it on your pillow, and then now they're they're in there or in the trash with some of your stuff. Anyway,
I haven't heard of cats and dogs dropping though. I mean, this has been out for many decades, and I don't see pets dropping from it. But I do think the
compliance is so terrible. People aren't actually using it.
That's a good point. That's a good point. Okay, fine.
But
I guess we should put a warning label on it.
Yeah, I don't know if there's one on there, but if not, then that should be very clear. The biggest problem is this, people, and usually it's the doctors, it's all of us that patients are seeing. It's not just like they go to the online or the pharmacy and they pick something up. They're going to doctors. I even have like colleagues who they're like, oh, but like I'm good. I've been on minoxidil, but I'm still losing my hair. So they're, let's say, I don't know, 25-year-old, they're thinning, they're losing hair, man or woman. They have androgenic alopecia. They go to a physician. The physician says, you know what? I know exactly what you need. It's Rogaine, topical minoxidil. Like, go use it. You'll be fine. And it's like not doing anything preventative. So while they might get a little bit more thickness to some of those villous hairs, that it's not preventing further loss.
How is oral preventing it more?
It's not. It's not. But for that indication of like making the hair thicker, it's so much more effective. Just from the standpoint of like it just makes it fuller.
But it's an FDA approved drug, so it had to have data.
The data is. I mean, I've reviewed some of the data. It's better than like what
it's good
the
when
other
we disagree,
were.
Right? Because I looked at the data for women.
Yeah.
Well, so in a guy, I could see a little bit more because he can be hairy and it's not the end of the world, but it's not specific to the scalp. So my concerns, so you'll make me feel better. My concerns are pericarditis, which is not dose related.
Yeah,
pericardial fusion.
I mean, there's like one case report for low dose, very low dose. Oral
it's not dose related. So I think it's underreported. These are my concerns, but I'm
fair.
I also have concerns about JAK inhibitors. So I'm less of a drug
Finasteride
person.
too is
Yeah, finasteride also.
got its issues.
But finasteride's been out again. It's FDA approved for this, and I use dutasteride. So I mean, I have issues and I don't have issues. But the bigger issue for women for me is that it's not specific to the scalp. So I see women who grow hair, but they also grow hair.
Yeah, it tends to be more like on the side of the face. Sideburns
and the
can
arms,
get worse. Right.
From oral more than topical.
Which dose do you usually go with for
women?
Oral? Yeah, for women.
0.7 to 1.2.
Yeah. Same here. Pretty much that range. For guys, we usually start at 2.5.
Yeah.
I really don't see many issues. I mean, that's probably the worst of it.
Peripheral edema? Never seen it.
I never see it. I see palpitations from time to time, headaches, lightheadedness here and there, but it's so rare. And those symptoms like are dose dependent. So maybe the pericarditis is not, but the other ones are. So I do like it, but again, it's like what are we using it for? So
Right.
if someone is, if a woman has, like Ludwig 2, 3, whatever, and we're just trying to thicken up the hair, it's fine. But like if we're trying to prevent further loss, which really, in my eyes, is the most critical thing, that's just not, it's not the answer. It has to be something anti-androgenic.
So if you're thickening the hair, isn't that preventing the miniaturization? Because you're making it thicker, which is less miniature.
Yes, but ultimately they still lose. Like the hair still continues to drop off. I mean, that's just
Over
what
time.
I've observed. Yeah, over time it still drops off.
I see that still with finasteride too, to some extent, and I think that could be dose related. I mean, you can stabilize it, but it also depends. Like if I see a young man in their 20s and they're balding, I mean, those are strong genes. I see women in their 40s and 50s who are thinning. I feel like we have a chance to stabilize them better. But unfortunately, I see a lot of even women in their 20s who are essentially balding.
Yeah, for sure. Yeah, women get affected, maybe not quite as often in early age as men do, but for sure they go through a lot of problems.
Do you use finasteride for women?
Not
Now I'm picking your brain.
premenopausal.
Let's do this interview differently.
Usually spironolactone is kind of our go-to, but finasteride not often for premenopausal. Postmenopausal, we'll sometimes try that, but I do like spironolactone more for women. And yeah, I like low-dose oral minoxidil, but the topical minoxidil, I haven't been impressed by the results for like what it actually, I think, is intended for. And then the prevention side, I don't see much efficacy. And on the finasteride dutasteride side, at least for guys, so like I find that maybe 5% break through like the standard 1 milligram a day dose. They still have hair loss. So that's who I switch over to dutasteride at 0.5 milligram a day. And very rarely do I have to like bump that up to 1 milligram a day, but I've never seen anyone break through that.
I usually start it even at twice a week, and then I'll have them do finasteride the other days, and then I'll bump them up. And I spoke with Ken Washenek, who was he's a dermatologist, but he's chief medical officer for Bosley. But he's super, super, super smart and very into this stuff. So he was like my go-to source for this for many years, because I know him from when he was an intern with his ponytail. I was an intern at Bellevue, and he was a first-year derm resident.
Yeah.
And all the nurses there adored him because he was tall and handsome and had a ponytail, and like they would put all his IVs in, and the rest of us were like, yeah, go do your own. So.
No, yeah, that's interesting, blending the two. I haven't really done that, but at least in my review of the literature, the dutasteride side effects are a bit higher. Some like
that's why I do it twice a week.
Yeah,
because it has a longer half-life, so it seems to not have the side effects. And sometimes I'll just do the dutasteride twice a week. Mm-hmm. But if I'm transitioning them over, I find that I'll go 2 or 3 times a week, and if you go up slowly, it's a little bit easier in terms of the side effects. But just playing around with it. And then if someone has side effects, stop.
Well, right. And then I just de-escalate the dose. So just spread out the days, lower the dose. And sometimes I drop down to topical finasteride. But I can almost always find... Yeah, again, I think it's like the minoxidil option. It's like the topical, just like less potent, but it's still going to do something. There's still going to be systemic absorption, whatever. But the topical finasteride I like, but I don't like to start there. But many patients come in wanting that because they're like, oh, it's better, like fewer side effects, right? I'm like, yes, but you're also going to probably continue to lose more hair.
But it's also still absorbed. I mean, you're not getting, so...
It's just weaker. It's just a weaker form of it. But at 0.3%, I have seen very few side effects, even for people who were affected by like half a milligram of finasteride every like 3 days. Then I'll drop down to 0.3% topical. And then I've had to drop down to like 0.1% for like 2 patients. And then they didn't have side effects and their hair was like more or less controlled, the hair loss. So
well, there's a
anyway.
really interesting book. It's not a new book by Nancy Edkoff. I don't know if you've heard of it. It's called Survival of the Prettiest. And she talks about hair is a big part of it. And what she shows, she's from, I think she's from Harvard, super smart PhD. But what she talks about is that hair is very tightly tied to our self-esteem. It's not that anybody cares, is choosing to care and perseverate about their hair. It's that hair is a sign of fertility and youth and health. I mean, if you see, we're talking about animals and being toxic to animals, but if you look at an animal that has a mangy coat of hair and that's like patchy, balding, you think that's like a viable animal that I'm going to adopt and it's going to have a long life? No, you think it's got some disease and it's going to die soon. So we have that same instinct. When you see somebody with a thick, full head of hair, then the idea is that person is healthier. And
unless it's a wig.
yeah, well, these days you can't tell anymore between extensions and wigs and all the other things people do, which I think is a lot of fun, but also can be problematic. But that hair really does convey a lot. And you could look 10, 20 years younger or older. I mean, the first thing when we came in, I was like, I didn't do my hair.
Don't worry.
About my ponytail.
Neither did I.
Exactly.
You're fine.
You're saying it, that's so good. But it is something that makes a big difference. When I walk by a mirror and I'm having a good hair day, I'm like, I'm more confident. And we're back to confidence, right? Hair is so powerful for that. So it's a really important accessory. And while it's not vital for life, it is in many ways vital for our self-esteem. Yeah,
many of, especially my male patients, they'll find that like they've been covering up with hats for so many years. And that is like something I hear all the time. It's like they come back at a year and they're like, I haven't really been wearing hats anymore. And like, that's really nice to hear. So I wanted to get back to some skincare stuff.
Let's go.
You're such a pro. So there's been like just an explosion of options and sometimes people don't know what to do anymore. There's just like so many companies, so many things. And so how do you think of it as far as like how many like steps, some people are like 14 steps, 4 steps. Some are going like no steps with like the no skincare fad and like the no washing. They won't wash their clothes. They won't wash the dishes. They don't
I don't want to be near
them. Yeah. But there's like all these extremes now, I feel like. So like, how do you advise patients on that?
Well, I just published my 4th book. This one I wrote with a colleague who's a PhD, Thomas Hitchcock, and it's called Rebooting the Biome. And it's all about the skin microbiome, all the bacteria and microorganisms that live on your skin. And what we know is that you do have a whole bunch of things living on your skin, and they can help you. They can do really good things. When you use a whole bunch of different products, they all have preservatives, right? You're using 5 products. That's 5 different preservatives. You're annihilating your microbiome. And a lot of those ingredients also, like sometimes even natural ones like bakuchiol, are not necessarily biome friendly. So a lot of what I look for now, it's really changed the way that I use skincare and prescriptions. I almost never use antibiotics anymore. I've switched. I use some topical ones, but not oral ones as much as I can avoid it. Like 99% of oral antibiotics for acne, especially in rosacea, gone. Because I find that if I can curate and use those microbes in your skin and sort of help them do the work, you'll have better and more lasting results. So a lot of what people are doing with the over-exfoliating, the over-cleansing, the using so many steps is that they're trying to replace what the biome and what the skin naturally does, and they're creating problems. I've tended to simplify routines down to just basics. I like vitamin C in the morning. In the morning, just rinse with water. A vitamin C cleanser. I do like exosomes. There are some topical ones. Plated and Elevai are 2 brands that I think have done the best work in terms of data showing that they actually do something. And exosomes are simply made from something called extracellular vesicles. So a cell wants to give information to another cell, so it packages it into this vesicle, little bubble, and then sends it off. That's an exosome. So an exosome isn't a thing in itself. It's simply a messenger. And it could carry good messages or bad messages. So it's a bad cell can be called carrying cancer messages. So you have to know what's in that exosome. But these ones, one is derived from platelets that's plated, and Elevi is from Wharton's jelly from the umbilical cord. So they're very good sources. They go through a whole process. There's no DNA in them, and they are carrying peptides and growth factors and all sorts of good things to help your skin replenish itself. So that supports the biome. And then there's a product called BioJuve that's actually skin probiotics, and it doesn't have preservatives because it's skin probiotics, not gut probiotics, not yogurt probiotics, but actually true skin. It's made of C. acnes, which is what we're always trying to kill when someone has acne, but it's actually a good strain of it. And it helps replace the bad ones with good ones. So it's great for redness, scars, wrinkles, all sorts of things, because it's making your skin do what it does. And then the postbiotics from that work like vitamin C and retinoic acid. So your skin naturally, if it's healthy, actually does a lot of what we're trying to do by adding retinol and all those things, but it does it organically. So it's like, I always ask people, do you think about every breath you take?
No.
No, but you breathe. And if you run, you'll breathe faster. And when you're sleeping, you might breathe slower, but you breathe. And here we are trying to control and micromanage our skin when your skin can take care of itself. Your skin even has its own innate immune system. It has Langerhans cells. And it's made to be exposed to the outside world. It's made to be exposed to germs and microbes and all sorts of things trying to invade it and to protect you from that. So if you just try to have a healthy, intact barrier, protect from the sun, eat a healthy diet, drink enough water, the gut biome definitely affects the skin, but don't overload it with a million different things. But it's tempting because we get marketed to all the time, and there's so much out there, and it's kind of fun to try stuff, but maybe only try a few things at a time.
Right. I wonder if there's a way to like personalize the treatment to the person's own skin biome. Like, are people trying that at all? Like sampling
there's
it?
Commonalities of our biome, so there isn't really much difference. We know that as you age, your diversity of the biome decreases. If you have eczema, your biome decreases. And when we do a culture, we swab for what's overgrowing. We look for staph or strep or pseudomonas or something that's overgrowing, but we don't look for what's missing. So we don't say, what does a normal biome have that would control those by itself? We just say what's overgrowing that we have to kick it with an antibiotic. And sometimes you need an antibiotic if you have cellulitis or an infection. You need help at that point because your biome is lost. But most of the time, we don't think about what that healthy biome looks like and try to restore that. We're always looking for what's wrong.
Right. Yeah. I mean, I had my friend Austin Shang on recently. He's like a big GI social media doc, and he recently wrote a book, and we were talking about like the gut microbiome and like even like fecal transplants and that sort of thing.
Cool.
It is.
Does he do that?
No, that's not really. He's like advanced endoscopy, but now he's like with Medtronic on the device side, so he wears many different hats. But with this fecal transplant idea, it's like it's not that one person is necessarily super ill. I mean, maybe I guess they could have like an autoimmune condition, and you're trying to combat that by taking the feces from another person and like putting it into a pill and taking it and trying to change. So I'm just saying maybe something like that, but for skin. I don't know.
The skin is too
It's
exposed.
Like too exposed.
Yeah, it's too exposed. Well, I mean, when you think about it, the gut is kind of outside you also because it goes through you, but it's not, it's still
connection points to the outside. Yeah.
It's all connection points to the outside. So, but somehow it's not exposed to the air the way we are, or the environment or pollution that's always trying to attack us. And also the layers of it. When we look at eczema and psoriasis, there's actual effects of different skin layers that are missing.
Right.
So,
and there's that connection too, that gut-skin connection.
But the gut biome affects that
which is
so
interesting.
much.
Yeah.
There's a really good article by Dr. Haynes Ely about psoriasis, and it's called "Is Psoriasis a Bowel Disease?" And he came up with this protocol where if you stop alcohol, just give up alcohol for a period of time, doesn't have to be forever, and anything hot on the tongue, anything spicy, no hot onions or peppers, and then take Duozyme, which is you buy it on Amazon, and which is bile acids, and quercetin, which is a polyphenol. Then he said you could cure psoriasis. And I had a few patients do it who had pretty bad psoriasis who either had failed biologics or didn't want biologics. And I said, try it for 3 months. I mean, what do you have to lose? So they did it. And quite a few of them were completely cleared.
Yeah, it's amazing.
And it was about leaky gut. So he thought that there were a bacterial cell wall. And I think this is true with processed foods, that the more processed the food is, the earlier in the gut it starts to break down. So it doesn't even reach the intestines where the microbes live. And when they eat food, things that have fiber, they make products that help you digest. So I always think, like, if you eat good food, you're actually not getting all the calories because the bugs in your stomach are eating some too.
Yeah. We have to share.
So the
they
more
outnumber us.
they outnumber us,
Yeah.
but they don't eat that much. But when you eat the wrong foods, then all of it goes to you in all the worst ways, but also creates this leaky gut problem, which causes inflammation. And so the two things that I think age us the most, one is inflammation, and the second is something called mTOR. Have you heard of mTOR?
Vaguely, I do remember that term, but I don't.
So mTOR is something that I've been working on for a while. And mTOR, I always think of as mammalian transcription of rapamycin.
Okay, yeah.
A mammalian
Vaguely
target
familiar.
of rapamycin, but I think it's now called something else, mechanical target of rapamycin. But anyway, so mTOR, think of that in my grandson who's 2, your child who's almost 5. They need mTOR because mTOR drives development. Think of that as like you're the pot of boiling water, right? Your development is the water heating. The heat is the mTOR. So at some point, the water heats and you're done. You need to stop heating it. You're going to pour the water off, use it, but the mTOR doesn't turn off. So eventually the water boils off and then the pot starts to burn and then it degrades. That's us as we age. That's the functional decline of age. Now, through evolution, we didn't usually die of old age. We died because there was a predator that killed us. There's accidents. There's all sorts of things that get us before old age. So this whole process, and we weren't really needed. Once you're old, you have kids, you live to raise them for a while, and then that's it. That's the whole evolutionary pathway. Of course, we've learned to outsmart that and live longer, thank God. But as far as mTOR is concerned, it doesn't care. So by taking a drug like rapamycin, you can block the mTOR pathway, which can slow the functional declines of age. Now, rapamycin was FDA approved for people who have kidney transplants to help prevent rejection, and it's as a cancer therapy. But actually, there's good studies that show, and more need to be done, show that it actually rejuvenates the immune system. So it's one of those anti-aging drugs that's getting super hot now. And I've been working on a form of it for skin and hair that hopefully will eventually have both an over-the-counter and prescription form of it. But this is an area where I think we get into what I call longevity beauty and longevity medicine, where we look at the functional declines of age. Hair is probably the most difficult one to address. But if you think about arthritis, collagen breakdown, things that happen around menopause and perimenopause, all of those functional declines of age could be affected by affecting both inflammation and this mTOR pathway. And it is going to change the way that we look at aging and look at health. I think menopause is another area where it's probably the biggest travesty in medicine is that we don't educate women or doctors on the importance of hormone replacement therapy. And I always know when someone's in perimenopause because they come in and they go, one day my face just fell apart. You lose 30% of your collagen in the first 5 years post-menopause. So we don't stop needing estrogen just because we stop making it. And the idea of replacing it is, to me, a no-brainer. It helps with dementia, osteoporosis, heart disease, collagen breakdown. I selfishly care about the skin, but so much of what happens around perimenopause is in the brain, not even just in the skin or the ovaries. And that hormone replacement is really important. And for men also, but it's different for men than women. But we both need hormone replacement over time. And for women, once I explained that hormone replacement is lower dose estrogen than in the pill, which they were on for 20 years and didn't think twice about. But this is less estrogen. They're all trained to think only around breast cancer. And that just is data that's so flawed because they looked at relative risk, not absolute risk. So the relative risk is high because it went from 4 out of 1,000 to 5 out of 1,000, but it's still only 5 out of 1,000.
Right.
Instead of 4. So the absolute risk is still 1%. It's still low.
So low, yeah. Mm-hmm. And then in terms of, I don't know if this is related or not, but this like increased trend of adult onset acne, is that somehow tied to this or not really?
Well, it can be a sign. The adult acne in the 20s or adult acne is in the 40s and 50s.
40s, 50s.
That's a sign of perimenopause.
Okay.
So it's acne rosacea. And yeah, that is a sign that your hormones are shifting. And we do treat it a little bit differently in that your skin is a bit drier. So you can't necessarily use as strong or high concentration of products as you could in your 20s when you sort of get that oil slick around your period. But it's also managing the hormones makes a difference. A lot of the women have come off their hormonal contraceptives. They're done having kids. Their ovaries are starting to shut down, and they're really feeling it in their skin. Alcohol and inflammation play a role in that as well. And unfortunately, as we get older, we don't heal as well, so the marks left behind can look bad. The other thing that's really interesting that I've seen over my years of practice is that acne scars that look mild in your 20s look deep in your 40s, because what I've observed is that with collagen breakdown and less of elasticity,
right?
So now I'm way more aggressive about treating acne scars in my young patients because they can still make collagen. So I have a better chance of getting them to as 90% or greater clear, not always, but as much as possible, much better than when they're in their 40s or 50s and now they have all this atrophy around it.
Interesting. On the note of rapamycin, it made me think of like how 5-FU is sometimes used for scar remodeling, even the scars that have been around for a few years. I don't know if there's any interplay there, but I was thinking like chemotherapy agent, kind of trying to reduce inflammation. So I don't know if that.
Yeah, it does. And also a little bit of atrophy. So yeah, 5-FU, 5-fluorouracil has been such an incredible drug, even around nodules from fillers. We use it. So it's come in very handy in both topical and injectable forms. For skin cancer, I combine it with vitamin D, and I find that really lowers the side effects from it because you get very red and irritated, and optimizes the results from it. So there's lots and lots of ways we use 5-fluorouracil, but I try to avoid it when I can.
Yeah.
It's like if you're using it, something isn't right. So I don't like using it.
Yeah, I didn't train with it very much. I remember when I started my practice, I bought it just to have it.
Yeah.
Some people would combine it with Kenalog, but I used to just use Kenalog. I still do for hypertrophic scar.
So what I do for that, which works really well, even almost if you have it, is I use a CO2 laser and then I put the topical Kenalog on. So instead of injecting it, I'll put it topically, and I find it gets in really, really well, doesn't hurt, and works amazingly well on scars. So it's laser-assisted drug delivery. It's like a whole new area of medicine and aesthetics. So if I do a CO2 laser, I'm always going to use exosomes, growth factors topically to help drive that in, because I created these channels and now I want to deliver actives. So now whenever you create a wound, the idea is to optimize the healing and the outcome with what you deliver.
With the exosomes, as far as I'm aware, they're not yet approved.
No, they're not.
Do you still...
I don't inject them.
Okay,
yeah,
so just
I
more
won't
on the
inject
topical.
Them. Just topical.
Side.
Yeah,
okay.
You can inject them. The FDA does not want that.
Right, because I know people are doing that for the scalp in some clinics.
Yeah.
And I'm just like, I don't feel comfortable until they look into it more.
It's a pity because it works really, really well.
Yeah.
But unfortunately, because there's no standardized protocol, and companies aren't willing to spend the money to do it because enough people are just doing it. But yeah, the FDA doesn't like it. And I think the smart people are being very cautious about
exactly.
that.
Yeah. We talked about fillers already. Anything else to add about this whole idea of like overfilling and filler fatigue? And I mean, I know we already kind of touched on that. We know that fillers last for a long, long time. There's MRI studies now coming out kind of proving that. But anything else you want to add about fillers and kind of almost like their overuse globally?
Yeah, I think we're kind of coming around to it where people are recognizing that fillers don't technically lift in most cases. I think sometimes they can, depending on where they're placed, but fillers fill and lifting devices lift, or surgery will lift. we're still in the infancy of what we can do with these products. We're still learning so much about it. Once cannulas came on the scene, so a needle is a blunt, is a sharp delivery mechanism, and a cannula is a blunt delivery. And I think with a cannula, you can be in many ways more precise in certain areas. The lips, maybe not, but everywhere else, or the plane of the skin. So now everybody has such strong opinions. I see people on Instagram teaching that you should never put a needle straight in and just put in a bolus of any amount, that's dangerous. Somebody else is like, use a cannula, but always be moving. Use a needle, never be moving, because if you move, you're going to move into a vessel.
Aspirate?
Then aspirate is dangerous. Not aspirating is the end of the world. Like
extremes.
Everybody has an opinion on everything, and they publish these things, which is crazy because these become legal documents. I think the important thing is to understand the products we have available, the differences between them, because there are differences from the product. There isn't one product that will do everything. You need a softer product around the mouth. You need a more robust product with different rheology in the cheeks or the jawline or the chin. And then how you deliver it, how much you can put in a spot, all of those things, there's so much nuance to it. Under the eyes, I've learned 0.1, 0.2, and I only use Restylane there.
Yeah. Restylane L.
Restylane L. That's the only thing. Yeah. And very low dose, small amounts, and then just gently mold it if you need to. And that's it. You go for undercorrection in that area, it will self-correct beyond that, or they could come back in a few months, you can evaluate it again. But the idea of putting a syringe under the eye, which I've seen, my goodness, or we know now we've spent more time studying ligaments, and I already knew this because I saw it, where if you have your lateral retaining ligament, if you inject behind it, you're going to get more of a lifting, an optical lift, if not an actual lift. And if you inject in front of it, you're going to get a bigger apple. And I see some people with these big cheeks because they're in front of that ligament.
Medial cheek is overinflated. And then you do a neuromodulator from above, you drop the brows, you overfill from below, you push the eyelids up, you end up with these small snake eyes because you make the eyes smaller from above, smaller from below, big cheeks. The further away your eyes are from your skin, from the surface, the older you look. And so people end up looking either older or unnatural. And I think the eyes are the rate limiting factor. The orbit shrinks, which means the hole gets bigger and the eyes either sink in or drop. And you have to work around the eyes. So the eyes are going to limit how much filler you can have in the face, because ultimately you're either going to change the distance from the surface, you're going to change the shape, or it's going to be out of proportion. So the eyes for me are the key. Yeah, that's right. The kind of limiting factor, and also what kind of guides your injections around the face. It makes sense. There's been a trend of these DIYers when it comes to fillers at home. And I guess best case scenario, they're using like the Hyaluron pen. Worst case, they're just, barehanded, just going at it into their face with the needles. I mean, I think it's still a small group of people, but sometimes it seems like they're loud on the internet. I don't know. What do you say to those folks?
Stop. Don't do that. It's dangerous. I mean, know your anatomy. It actually makes me uncomfortable when I see doctors injecting themselves.
Right.
I don't like seeing that either.
I've never posted anything like that from myself. I mean, honestly, I don't do Botox. People are surprised. It goes back to, I think, the kind of like, because I think my affect is usually pretty calm and like steady.
Yep.
And like, I think I show that on my face. I'm not always like going crazy with the expressions.
But you're very expressive. You're just not doing that. And I think you naturally pull your ears back. I think you are naturally expressing laterally, because the essence that you emote is presence. So when you have that lateral expression instead of up, when you go up, you're trying to force yourself to be relatable. When you go laterally, you become relatable. You become present. So when I sit and I put my ears back and I do that facial posture, then I am now here. It makes you land where you are. It is so incredibly powerful. But I think you live there naturally, and that's a great thing. I mean, that's a gift.
Yeah, I don't think about that, but thank you. It's nice coming from you.
I've been seeing it this whole time. Yeah.
Thanks so much. Just to get into this about non-surgical, like less invasive procedures versus more surgical procedures. I think people are confused about what's more dangerous. I find that sometimes there are certain surgeries, at least when I used to do injectables and did like, facelifts and all this stuff. There are times when I felt more comfortable doing an open procedure where I could see
Yeah.
the anatomy than certain injections where I was like, I think I'm good, but I don't know for sure. And like, in the back of my mind, I had all these pictures from the books and from the meetings of, these vascular occlusions um and also when it comes to lasers, especially in the wrong hands, it can be quite dangerous. And these fillers that don't go away. I mean, there's I think lots of like non-temporary effects of non-surgical procedures that people they don't really know that, so they come in and they think, oh, I'm not getting surgery, I should be safe, but then it turns out they're not. And then of course, on the other end of the spectrum, you've got surgeries, and those have real risks. So how do you in your practice I guess just like again educate patients on those options, and at what point do you say like, you know what, maybe surgery is the better option?
Well, I usually start with a question of, would you have a facelift? And the person who says, yeah, I'd consider it, I refer them to a plastic surgeon, because somebody who has a facelift in mind is not going to be happy with not a facelift. So the person who I want, the patient that I can work with, is a patient who says, I've had a facelift, I want to maintain it, or I will never have a facelift. I'm in that category. I will never have a facelift. And I think I'm old enough to know that I still feel this way. And
How come?
um, because I feel like I like being older and I don't mind looking older. I just want to look good, period. But I'm not fighting age in that way. Trust me, I do treatments in my office, and I get fillers once a year, and I'll do my neuromodulators every 4 months or so. And I'll do soft wave a couple of times a year for lifting. So I'm not saying I do nothing, I do plenty, but I like being older. I'm a grandma. I love all that stuff, and I'm really happy. So, and maybe also because I don't have a lot of excess volume. If I had a turkey neck, I'd probably do surgery, but it's not my problem. And so I think on the one hand, I did do my upper eyelids. I don't think of that as doing a facelift, because that was just excess skin, again, the eyes, but not my lowers. But that's the only surgery I've done. And I'm just happy enough. So maybe if surgery changes, and I think when you start to rebalance the face, redrape it, you are affecting ligaments and muscles. And I don't know that it always ages well. And I just didn't want to go there. So I'm happy enough, and I'm okay with aging. Understanding that I exercise, I have my Peloton, I lift weights, I try to eat well, I intermittent fast, I take my supplements, I do all those things. I have social, like all the pillars that I can work on, I'm working on. And then I'm trying to avoid surgery.
And just to make it clear, you look fantastic and you don't need any surgery. But
better when I get my hair done. Saying it again.
But it's just interesting to think about like risk tolerance. I think that's a big thing for people when they say, oh, I would never get a facelift. I think some of it maybe has to do with what you're saying with like, just being comfortable in your skin and being like, like I'm older, like that's okay to look older, as long as I do everything else that I can. But some of it, I think for many people, comes down to like, look, I don't want to have like my face sliced open. And I think that's very fair too, just to say that not everyone wants that. There's real risk. There's real downtime. It's not for everyone.
I agree. And also I know enough because I see people coming back after a facelift and they all do the same thing. They all go, I just wanted this much more.
Yeah. Well,
once it relaxes, they want more.
doing that surgery.
Yeah. It's this much more.
They think it's one more stitch. It's just like, just a little stitch. And it's like, I got to redo that whole thing.
No. And also the skin relaxes and everything ages. So you have to maintain it. But it's also that I'm not competing with a facelift. What I do is not intended to be a facelift or to look like a facelift. And the costs are getting closer. I mean, facelift costs are going up a lot, so we're not really near there. But if somebody thinks, well, I'm not going to do a facelift, it's going to cost me nothing to do the other stuff, or just I can do this because it can't be very expensive. We have so many different things we do that it does start to add up. And then somebody will say, well, if I'm going to do all this, I might as well just have a facelift. It's missing the point. They're two different things. They're two different mindsets. They're two different approaches. And what I do is not meant to either replace a facelift or compete with a facelift. It has its own space. And absolutely, you have to talk about the risks of everything. So when I do a filler, I always, on the first visit, and sometimes on subsequent visits, depending on how long it's been, we'll talk about the risk of vascular occlusion and blindness, because anywhere you inject, no matter what technique you use, that is a risk. But there are ways to mitigate that. So fortunately, I always knock on wood, in 21-something years of practice, I mean, in the beginning, we didn't even know it. And thank God it's that rare that we didn't even worry about it, because we didn't even know to worry. And sadly, people are injecting and they don't know to worry, but they're not even trained enough to understand the anatomy or what could go wrong, and they don't have what they need in case someone did go wrong. So that's really scary. But also there are techniques, injecting slowly, looking at the skin when you inject, not using more than you need in an area. Just there's
knowing
so
where the
much,
major vessels lie.
generally where they lie. You don't have to know what they're called, but you should know where they are. And if you hit it, stop.
Yeah.
There's so much you can do. I always say, when you're in a hurry, never rush. Always take your time with the injections, no matter who's waiting, what else is going on. When you're injecting, your focus is on that patient, that injection, and paying attention to what you're doing. And then as we learn, we adjust. We used to use smaller cannulas. Now we use larger gauge ones and still go slow and still look at the skin. But I avoid the nose, because then it's where you're comfortable. Like, I'll inject the temple all day, but I won't do the nose or the glabella, because I don't.
I used to do the nose, but not the temples.
Yeah, exactly.
Everyone's got their
Everyone,
area.
and it's where somebody scares you the most. So,
yeah. Right. Yeah. I mean, I think what some people get wrong is that they think that for especially certain types of areas, like they think I'll get filler to try out surgery.
Right.
And then if I like it, I'll get the surgery. And I think the best example for this is the nose, because it's like they have a little hump, and yeah, you can inject above and below it, and you can give them a straight dorsum, but like you've given them a bigger nose. And most people, when they go for rhinoplasty, they end up with a smaller nose. I mean, generally speaking. And so it's a different nose. It's a different result. So you're not really, same thing with the lips too. With like,
I can't even watch nose injections sometimes. It doesn't seem to hurt as much as it hurts to watch.
Yeah.
Because it seems
they're all
like
blanched, and it's
I don't have the stomach for that.
Yeah.
So, but there are people who do really well with nose injections, but you only see them immediately after. You don't see them 5 years later. And I wonder what the consequence of that is. Does it widen the nose over time if you
can? It can, yeah, because the structures can only hold so much, as you said, like for the lip as well. And so it tends to just diffuse out. So I've definitely seen that widening over time. Yeah, for sure. These are questions from the YouTube community.
Okay.
I told them that we'll be chatting soon, and people, well, there were lots of comments, but these were like the first that I could grab, and then I kind of stopped reading them. There's so many. But so the first is, what are the current trends for non-invasive procedures? What can you do at home versus what you'd recommend a salon for? For example, brow lamination is something you can fairly easily do at home, but microneedling doesn't seem like a good idea.
Oh, I think microneedling done well, or microblading.
Maybe she meant microblading.
Yeah, microblading done well is pretty good. I've seen it done well and done poorly. So you definitely want somebody to go slow and say, well, we don't have to do the whole thing in one visit. Do it over a few sessions and just do a little bit at a time to make sure you like the color and the way that it looks and that it looks natural. But laminating is also fine for the brows. In terms of what the trends are in the office, I think it's really a combination approach of, now we understand a lot about anatomy, how the skin and the face ages, and we can use a combination of neuromodulators like Botox or Dysport or Daxxify, fillers, different fillers for different parts of the face, and devices to help somebody age really well. And you can do these over time so that you don't have to wait till you fall behind and then have a facelift. You can do small things from a relatively young age, and do a little bit as you go, and then just age really well, but always want to combine it with lifestyle. At home, it's really about sun protection every day, all year round. Always protect the neck, always go up so you get the bottom of the neck. Your neck is pristine, but always go that way so you get the bottom of your chin, shadows under here, protects that, but this is exposed. And then retinols are good, antioxidants like vitamin C. healthy diet, get enough sleep, minimize alcohol. Red lights are pretty good. There's some better than others. I don't know of any particular brands, but I think red light therapy and just being smart about sun exposure.
If she could only get one treatment for the rest of her life, what would it be?
Oh my God. It would be my soft wave because it does lift and tighten better than anything, but it's such
Radio frequency?
It's ultrasound energy.
Ultrasound,
and
okay.
It's 7 parallel layers that doesn't melt fat, and it tightens and lifts really well. So that's something that I really like, but I don't know. I mean, that's just such a cruel thing to ask.
Yeah.
It's like picking your favorite child.
Exactly. Okay. What are possible causes for skin to darken for no apparent reason in the late 20s, especially the forehead? Any medical reasons that should be considered?
Generally, it's melasma, and it's a little bit of sun on a cloudy day, especially in somebody who's been taking hormonal contraceptives for 3 or more years. So people will be on hormonal contraceptives, but they won't think about it because they've been on it for so long. And then all of a sudden they start making this discoloration. It can be on anywhere on the body. So usually it's hormones and sun. So it's either pregnancy or longer use of hormonal contraceptives. It could be friction from a hat or something that you wore that can do that. And then you create some trauma, get a little bit of sun, and it can hyperpigment. But in terms of what could be wrong, there is something called acanthosis nigricans, which doesn't usually happen on the forehead. It's usually the back of the neck. It's velvety and it's kind of dark. And that could be a sign that you're predisposed to type 2 diabetes or insulin resistance. So that's something else to look at. Doesn't typically happen on the forehead, but I've seen it there. And things like weight management, metformin, which I think is a great drug, that can help it too. So I would see a dermatologist just to make sure you know what's causing it for you, and they can get a full history and help guide you.
And slightly related to that, I've seen some post-hair transplant hyperpigmentation, especially like around the hairline, that can linger around for like a year, but then it seems to fade out. So,
but doesn't that make you seem like you have more hair because it's
yeah, exactly. Brings that hairline down a little bit more.
Yeah, exactly.
Yeah,
a perk.
Yeah, totally. Okay, next one. Just how much does diet impact skin health? For example, does eating 1 meal a day impact health? How about eating 20 grams of sugar a day? Is there a thing as too much protein, edible collagen, yay or nay? Just kind of.
Oh, such great questions. That's a great question. So collagen, I'm more yay than nay, but I don't think I would take it in a pill. I would do it in a powder or a drink. So that's the collagen thing. There is somewhat good data that shows that while it does get digested if you eat it, the building blocks that it gets broken down to does help build collagen. And some of the data, at least hypothetically, is good. It's not an FDA clinical trial. These are supplements. So no one's going to do a full trial, but some of them are pretty good. I think Nutrafol, Skin Aid, and Liquid BioCell are the 3 best ones that I've seen so far. I'm sure there's others that are pretty good. The diet makes a huge difference. I don't know about how much intermittent fasting by itself matters. I've been doing it for decades, and I think it does help to give yourself some gut rest. A minimum fasting time of 13 hours, I think, is reasonable, but I don't think it's viable for most people to just eat 1 meal a day, and nor is it necessarily a good idea. Everybody's a little bit different, so you have to see how your body adapts to it. Like, I usually start fasting at about 2 p.m. I don't eat dinner, but that's how
I can't go to sleep hungry. I don't know how you do it.
I don't. You don't get hungry. You get over it. Like you're hungry, and then you start to look forward to it, and then you're not hungry because your body gets used to not eating.
You adapt.
Yeah. So, but I have a good lunch. Breakfast is my best meal. So that does matter, and then the quality of the foods you eat probably is what matters the most. Having good quality proteins, good quality fruits and vegetables, berries, all things that are in season, ideally pomegranates, pumpkins, squashes, all green leafy vegetables, all really good for the skin. You can get too much protein, and protein can be a problem if you get too much. You actually need more protein if you work out more, and as you get older, you need a little bit more protein. But when you're young, you just need good, high quality protein, and it's going to vary depending on how active you are. But you can absolutely get too much protein.
Yeah. And collagen
is a protein. So you have to think about that too.
Yeah, and leave out the processed foods, like we said earlier.
Absolutely, the worst. I
Yeah,
mean,
that's
as
all
much
over
as
the
you
place,
can.
though. Yeah.
Yes, I have my what I call my terminal days. So if I was terminal, I would eat these foods. If I didn't have to worry about being healthy or losing the weight on the other side. So every now and then, I give myself a day where I eat like I'm terminal.
Yeah, a cheat day.
Yeah, or a cheat day.
So this is the last question here. What products, treatments to avoid for people of color? I know some things that typically work well for fairer skinned people can actually cause damage, like hyperpigmentation on people of color.
Absolutely. You have to be so careful. And I think of skin of color as being Asian, African American, I'm Middle Eastern. There's so many variations, and a lot of people have biologies or ancestry that's more mixed than they even realize sometimes. So I think you have to be especially careful. So what I think of is the laser, like a laser hair removal. I wouldn't use the typical laser. I would use a long pulse ND-YAG laser because the energy goes deeper and is less likely to cause that hyperpigmentation. And I control the energy. So usually if you're going to use a laser, you'll use less energy and you'll deliver it over a longer period of time. So less of it focuses on the outer layers of the skin and you're less likely to cause a burn. But in darker skin tones, they can tan easier, which means you really cannot treat them if they have had any sun exposure. Because when you get sun exposure, your melanocytes, the pigment-forming cells, are hyperactive. And if you then hit it with a laser, you're really going to knock them out or make them mad and make them produce more. So being especially careful to use products that might prevent that hyperpigmentation around the treatment and focusing on the energy levels you're using. Now, the good thing is darker skin tends to age better, so you don't need a lot of the stuff that fairer skin needs that doesn't have that innate protection. So the whole approach is different. And I find that neuromodulators and fillers are generally done the same way to balance to the ethnicity and what they identify as their roots, because you want to match their sense of their roots. But at the same time, you don't have the same worry about hyperpigmentation from injectables. And those studies have been done.
That's all I have.
Great.
Thanks so much, Dr. Day. This
Thanks
has been
for having
so
me.
informative. Thank you very much. Thank you.